Um, the last speaker of this morning session is Professor Kerri Winters-Stone. Her impressive research focuses on the effects of cancer treatment on musculoskeletal health and cancer recurrence. Today, I think we're really in luck because you're going to tell us about the trajectories, and that is something we really need to know more about. Thank you.
My talk is not specifically focused on cachexia, but I do hope that some of the preliminary data that I'm presenting out of a larger longitudinal study touches on some of the concepts that have been raised, as well as some of the methodologies that have been suggested, and provide some food for thought for future discussion. So I'm presenting a preliminary data analysis from the Pattern trial, and this is a National Institutes of Health funded observational study that's designed to look at longitudinal trajectories, both patterns and predictors of symptom development, functional changes, as well as fall risk in patients who are receiving neurotoxic chemotherapy for their cancer. Whoops, I'm not touching anything. Okay. You can start on the second slide, it's fine. Okay, we'll start over. That was Oregon. If you've not seen it before, it looks a lot like Scotland. Okay, so Pattern is this longitudinal observational study in patients. These are in patients who have early stage disease, because the idea is to be able to track longitudinal trajectories both prior to the beginning of treatment, over the course of chemotherapy, and into recovery. And during Pattern, what we do is we try to enroll the patient prior to beginning chemotherapy treatment, and then we are measuring symptoms weekly throughout their treatment, as well as 1 year into recovery. And then about every other infusion cycle, we're also conducting clinical assessments of their functioning, and we're also doing home monitoring of their mobility and their activity. So Pattern really gives us this rich opportunity to be able to ask additional research questions, and potentially focusing, at least in this analysis, on patient populations who may be prone to weight loss during their treatment, as well as functional decline. So the goal of this analysis was to examine the early onset of weight loss and functional decline in patients who were given a common agent. In this case, we focus on oxaliplatin, and looked at data from both colorectal and pancreatic cancer patients just over the kind of first half of their treatment. So we're looking at what those early changes are based on the data that we have. And we're modeling patterns and trajectories. I'm not touching anything, but this keeps advancing, so I'm not. Bear with me as as the slides get ahead of me. But what our analysis did was model both the patterns and the trajectories of change. Okay. See if we can go back. Sorry. It's like it has a mind of its own. Okay, so we'll try it again. So we're modeling patterns and trajectories of change over time in both patient-reported outcomes of fatigue and functioning, as well as clinical measures of strength and function, and passive monitoring of daily life mobility. So I want to spend just a little bit of time on our measure of daily life mobility, because I think it's quite novel and it might be something to consider in future trials. So daily life mobility is trying to understand the movement patterns of people in their real environment and their real day-to-day life. And this is potentially superior and more meaningful to clinical assessments of their functioning that we get episodically and that we get in a lab or a clinic setting where people really want to do their best for you, right? But now we're getting a little bit better picture. These are instrumented socks shown here. There are inertial sensors embedded on the top of the foot as well as by the ankles that can get kind of multi-dimensional movement and give us a really rich data set around both gait quantity as well as gait quality. And I'll go through some of these metrics kind of as I walk you through the data. So this just gives you an idea of the participants that provided data for this analysis. We had 27 patients with colorectal cancer and 18 with pancreatic cancer. About 2/3 of our colorectal cancer patients had had 6 cycles of oxaliplatin treatment at the time of analysis. The rest had slightly fewer due to various reasons, discontinuation, they hadn't yet reached their 6 cycles yet, or they discontinued treatment. And similarly with pancreatic cancer, about half had gotten 6 cycles of oxaliplatin, and the rest had fewer than that. But because of the modeling approach that we use, we can include all available data, kind of model patterns of change. So our analysis is what was brought up just a couple of talks ago. We used a mixed effect model so that we could look at the rate of change per chemotherapy cycle across all of our different outcomes using all available data that we had at the time. And then we can model both changes across cycles as well as changes between our different patient subgroups. So just to give you an idea of our sample, our colorectal patients were about 55 years of age. Our pancreatic cancer patients about 14 years older, mixed genders, primarily Caucasian, and you can see their baseline body weight below. So I'm going to walk you through what these graphs will tell you, and they will look similar for the rest of my results. But on the left, we have just what you would typically see in terms of individual means and standard deviations. The different symbols reflect the time at which the patient enrolled. So ideally, we want to enroll patients prior to their initial chemotherapy treatment. As many of you who work in the clinic setting know, that's not always possible. Either we couldn't approach the patient in time to get that baseline assessment prior to treatment, or they were unwilling to enroll the time because they were feeling too overwhelmed. So rather than just lose these patients altogether, we allowed them to enroll at their cycle 2. And then regardless of when they enrolled, either at cycle 1 or at cycle 2, we measured our clinic assessments about every other infusion cycle. And you can get an idea here of the amount of data that we had. The larger the symbol, the more data that we had at the time. So obviously the symbols get a little bit smaller since we had fewer patients later on. But if you kind of connect the symbols, then you can see what the trajectory of change was. And I think it's important, this way you can look at the pattern of change over time, but you can also look at the distribution and kind of the variability, where we might start to see patients who are changing differently than one another, and they're not all changing in the same way. And then on the right here, these are the mixed effects models. So we take all available data, we smooth it out, and can look at what the kind of mean trajectory of change is in a given variable. So just starting with body weight, and I'm going to focus my conclusions really on the mixed effects models, but you can see over their first 6 cycles of oxaliplatin, our colorectal cancer patients had a small but significant increase in body weight, and the pancreatic cancer patients had a small, barely significant decline over those first 6 cycles. And we moved to patient-reported outcomes, starting with fatigue. And one thing I tried to do in here was give you an idea of what the norms should be at baseline where they're available, as well as whether or not the changes that we observed were at least minimally importantly different, and when available, minimally clinically importantly different. So you can see that right off the bat, fatigue starts to increase in both patient populations, very significantly so in the colorectal cancer patients, and that change just in those first 6 cycles far exceeded the minimally important difference for fatigue. And moving on to self-report physical functioning, so patients' perceptions of how they're able to function independently. You can also see that this starts to decline in both patient groups, significantly so in both colorectal and pancreatic cancer patients, and these either met or exceeded minimally important differences for declines in functioning. Now, if we move to our objective measures, we measured muscle strength by hand grip dynamometry that you've heard a lot about already. If you kind of average the normative data across genders, you might notice that the baseline hand grip strength for both of our patients groups is below age-matched norms. It declines over time, primarily in our colorectal cancer patients, and nearing kind of a minimally clinically important difference in a short period of time. And then we also use the 5-time repeated chair stand test for our measure of lower body strength. Again, the baseline values for both patient populations fall below age-matched norms. I'm trying to hit the age-matched in the middle if we average the age across the patients. The values for chair stand time actually exceed a clinical threshold that indicate increased fall risk. This is before the start of treatment. And then there's a significant lengthening of the time to rise from a chair 5 times. So this obviously indicates a worsening of lower body strength in colorectal cancer. And then for functional mobility, we use a timed up and go test. If you're not familiar with this is a test where we ask a patient to start sitting in a chair, rise from the chair, walk 3 meters, turn around, come back to the chair and sit down. It's a very good predictive test, primarily in an older adult population. And you can see that the baseline values for our patients in both subgroups are lower than age-matched norms, but they don't necessarily change that much over the initial treatment. I wanted to bring up one issue with the timed up and go test when you're trying to do it in a clinical setting. It's not easy. There's not a lot of clinical space, and oftentimes in order to make your course, you have to do things like ask patients to navigate doorways, which changes the speed at which they move, or maybe even they have to go into the bathroom in order to have enough length for the course. So there's a lot of variability, and whether or not we get the same room for the patient every single time that we're assessing them is not a guarantee, so the course can actually change. And then daily life mobility with our smart socks. I have several slides, just we have several outpoints from this. So again, this is kind of daily life mobility, and kind of an overall measure of gait quantity can be found in strides per day. So this is how many strides are people taking, how many times they're getting up and walking throughout their day-to-day life. And you can see it's declining in both patient populations and significantly so in colorectal cancer. We can also get a measure of gait speed. So you've heard about gait speed. We usually measure it with a 4-meter walking test in a clinic or a laboratory setting. This way we get gait speed in the home. If we use the cutoffs for gait speed in a lab setting, you can see that the starting speed for both our patient populations is at or below age-matched norms, or even at the point where there's some potential indication of fall risk, and it does decline, so patient starts to slow in our colorectal cancer patients. And now we move on to gait quality. So this is the way you walk, and the way you walk matters because it has an impact potentially on your ability to do your daily functions, but it also has an impact on fall risk. So one measure that we look at is double support time. So this is the amount of the gait cycle that is spent with 2 feet on the ground. Really, we want a freely moving gait cycle with more proportion of 1 foot only on the ground. And you can see that the time spent in double support starts to increase over time during treatment. It does not become significant, however. And then toe out angle is a measure of kind of how toed out somebody's gait is. And typically when you're really stable, you don't have a wide toe out. As you become less stable, the toes move out, kind of splay out in order to preserve stability. So we are seeing some decline in, kind of a change, a more toed out gait in colorectal cancer. And then a couple of other metrics that are known to correlate potentially with the development of fatigue or weakness or neuropathy. One is elevation at mid-swing, so what's the foot clearance as somebody is walking? So you can imagine with neuropathy, for example, the elevation starts to decline. It also means there's less clearance and there's more opportunities for someone to not be able to clear an object, to step over an object, and the tripping hazards start to increase. So elevation at mid-swing starts to decline over time. And then we also see a measure called pitch at toe off. So that's how pitched is the foot at toe off. And when someone gets tired and they start to develop this more shuffling conservative gait, the pitch at toe off starts to decline. So we start to see that decline in colorectal cancer. So just to summarize, I think what we saw was in this patient population, it's a small sample, it's only 45 patients, and the data are preliminary, but nonetheless, prior to starting oxaliplatin treatment, both patient groups reported, if you looked at the means, they had low fatigue and pretty good functioning at the beginning of treatment, but they had objective measures of their mobility and their strength that were at or below clinical thresholds or age-matched norms. And over the first 6 cycles of oxaliplatin treatment, body weight changed differently in our 2 patient groups, but both groups reported worsening fatigue and functioning that either met or exceeded at times minimally clinically important differences. Colorectal cancer patients seem to have additional declines in their objective measures of strength as well as functioning, but our pancreatic patients were able to preserve most of their functional outcomes, and I have some ideas about why that might be. But I think overall what we saw was that weight change did not seem to correlate with changes in patient-reported or objectively measured functioning. And we recommend that we need to start thinking about incorporating patient-reported measures, either simple clinical tests that can easily be done in a clinical setting, or even passive monitoring approaches to be able to identify when patients are declining and when they might need intervention to reduce their risk of disability, preserve their independence, and prevent falls. Okay. I just want to acknowledge my collaborators and thanks for the time.